Good evening, ladies and gentlemen. I'm Dr. Umar Hamadi, internal medicine consultant and vice president of Emirates Society of Internal Medicine. It's my pleasure to welcome you all to attend this webinar to hear the latest updates on the COVID treatments. I believe we heard a lot about COVID diagnosis, COVID transmission, COVID vaccination, and now it's the time to hear more about COVID medications. I remember when we received the first few novel coronavirus cases in end of January 2020. At that time, scientists and specialists were wondering what was the best treatment against the virus with no written single line in Harrison's or Cecil or online journals. Should we start trials with medications which were tested in the previous coronaviruses, such as ribavirin, chloroquine, or Calitra? Or should we use symptomatic treatments only until we have a clearer picture of the virus behaviors and their responses? Now, after 1 year has passed, I believe we had a very long and remarkable journey. And it is time to look retrospectively on both successful and unsuccessful options of the medical treatments of SARS-CoV-2 virus. For this reason, I am so happy to moderate this session, which is organized by the Emirates Society of Internal Medicine. And I am so glad to have a very distinguished guest who worked very closely with the pandemic science from day one. Allow me to welcome Dr. Jihad Abdullah. He's an infectious disease consultant. He's head of infection prevention and control committee in Al Rahba Hospital in Abu Dhabi. He is member of the expert panel and the strategic planning team of tuberculosis in Abu Dhabi Health Authority. Dr. Jihad is a board certified by the American Board of Internal Medicine and the American Board of Infectious Diseases. His current area of research and teaching interests include viral infections, tuberculosis, multi-drug resistance organisms, and the prevention of healthcare-associated infections. And I know very well now he is very interested in COVID disease. This session will go as announced in the poster. Dr. Jihad will walk us through the main topic, emerging COVID medications, for around 4 minutes, for a Q&A for about 15 to 20 minutes. You can text your questions, as many questions as possible. And accredited session, we will have an NOP, and I'd like to thank them for sponsoring this important aspect of COVID management, which is, and welcome Dr. Niyaz Sheikh, Professor of Medicine in Dubai, to be the key speaker at this symposium, COVID medications. Yes, I can hear you, Doctor. So, Dr. Jihad, the presentation.
Okay, let me share my screen.
Dr. Jihad, can you try to speak? Just I could not
can you hear me, doctor?
I cannot hear.
Can you see my screen or no?
Can we get
yes,
help
doctor,
from
we
the
can
IT
hear you and
team?
see your screen.
Okay. And my voice is clear?
Yes, doctor, very clear. You can start now.
Okay. Thank you very much, Dr. Omar, for the nice introduction. It's my pleasure to present this session today about COVID-19 treatment options, what we know so far. And I'm gonna give my presentation as 2 case scenarios, and each case has multiple sessions, multiple changes, and we're gonna go through each case as like a normal, every normal patient we see in the hospital, and go through the treatment options, one case after the other. So let's start with this case. This is a 57 years old male patient with past medical history of diabetes mellitus, coronary artery disease, and obesity, admitted to the hospital with the diagnosis of COVID-19 infection. He's been having history of 2 days of fever, body ache, and dry cough, no any shortness of breath, no vomiting or diarrhea. His labs, as you can see to the right side, showed normal white blood cells with normal differential. LDH and ferritin are elevated. Procalcitonin is normal. CRP elevated, and liver enzymes are mildly elevated, the AST and ALT. His chest X-ray showed no obvious consolidation. His lung CT scan showed multifocal bilateral small faint patchy areas of rounded peripheral ground glass obesities or infiltrates, and the scoring, the severity scoring of that pneumonia or lung involvement was scored as mild disease. He is febrile, as we mentioned, and he has a persistent cough. Blood pressure is stable, 120/79. Temperature is 38 Celsius. No tachypnea, so respiratory rate is 20. Saturation, oxygen saturation on room air is 97%. He was started on favipiravir and Camostat, which are oral antivirals. And the question I'm going to ask, should we add steroids? Should we add dexamethasone to this patient? And to answer this question, let's go through some facts. So regarding COVID-19, it's always time. Time matters. So we have to look at the date of symptoms onset, not when did he have the first COVID positive. This will change a lot of things in the treatment. And this disease has two phases. We have what we call the first phase, which is the viral response phase, or we can call it the viral replication phase, that takes from the onset of symptoms up to 8 to 10 days. During this phase, the virus is replicating, and we depend on our immune system to tackle down and slow down this viral replication. So during this phase, anything can boost and strengthen our immune system gonna be beneficial. Anything will bring down our immune system and make it weak, make the immune system weak, will be not efficacious and will be maybe harmful. So for example, in this viral replication phase, you can use antiviral, you can use monoclonal antibody, and you can use even convalescent plasma. Do you think it's a good idea to bring the immune system down in this phase? Absolutely no, because we need every single cell of our immune system. Moving towards 8 to 10 days post symptoms, then you will enter what we call it the hyperinflammation phase. This is when your immune system goes very strong and start to attack the cells that carries the virus. At this stage, the alveoli is already infected, and you start having shortness of breath, and you start having some oxygen problem and desaturation. And later on, you might progress to something we call cytokine storm, which is a very critical situation that most likely end up with ARDS and sometimes death. So at this stage, when you have a very active immune system attacking your own cells that carries the virus, you need to slow down this immune response. This is a time when steroids or anything that can bring the immune system down will be beneficial. So again, let's summarize what I said. The first 10 days, we have what we call it the active viral replication phase. And during this phase, anything that can tackle down and slow down the viral replication and maybe improve the immune system is beneficial. So we're talking about antiviral, whether it's remdesivir, favipiravir, or we give passive immunity, giving the monoclonal antibody, or even passive immunity with the convalescent plasma. We do not recommend steroids at this stage or any kind of interleukin-6 inhibitors because it will decrease the immune system and it will not be helpful and may be harmful. Going to the next stage of the disease, which is from day 8 till day 14, and might go even longer. At this stage, your immune system is active in a very high speed, attacking your own natural body and your own cells in the lung and almost every single part of your body. But here we talk about the lung. You started to have shortness of breath as a patient. You started to have low oxygen, and we need to slow down this immune response, this hyper immune response. At this stage, of course, antiviral will not be effective. Most likely are not effective. What can be effective and good is steroids and any other medications that will slow down the immune response, and maybe interleukin-6 inhibitor antagonist might be also helpful. So let's see what recovery trial. This is the eye-opener trial in England. This is what we call the like a milestone of COVID-19 treatment because it changed the concept. Before this, we thought that steroids will not be helpful. Based on our experience before on the old SARS infection, but this is a different virus with different characteristics, and we learned a lot each single month with each study we had. So in general, if you look at the left side diagram, it showed that if you give the steroids in general, it's going to be helpful, correct? So the steroids versus the usual cause, the mortality is less. Go to the right side, the right diagram. If you don't need oxygen, based on the recovery trial, giving steroids to someone who is not hypoxic, does not need oxygen, this will be harmful. As you can see, mortality rate is higher in the early stage of the disease among people received steroids, received dexamethasone plus usual care versus only usual care. But going ahead in the disease, if you have progressed disease and you need oxygen, to the left side, to the left diagram, as you can see, if you give steroids, you'll have better survival and less mortality versus usual care. If you have more progressive disease and you ended up with invasive mechanical ventilation, this is when the dexamethasone will be most beneficial. So the more severe the disease, the better outcome from steroids and more benefit is acquired by giving the steroids. So back to our case. So the same patient, we said that his saturation is 97% on room air. Should we give dexamethasone? And the simple answer is big no. Saturation is okay. We still add the viral replication phase when steroids will not be beneficial. In fact, it might be harmful and decrease mortality. So my first message, do not give steroids to someone with normal saturation. And the cut is 94% on room air and above. When you reach 94% or less, it's time to give steroids. It's time to give dexamethasone. So we are now on day 3 on the same patient. He is still having fever and dry cough. His vitals are stable and his temperature, as I said, is still high, 38.2 Celsius. Saturation is still acceptable, 97% on room air. His labs are showing a white blood cells of 4,000, CRP 46, and his procalcitonin is 0.01. His blood and sputum cultures are still pending. Chest X-ray was done because of the persistent cough, and it's showing no changes, no any new infiltrates, the same as before. there's a medical resident taking care of the case, and he approached you as a specialist or as a consultant asking whether we need to add antibiotics because the family is requesting that. They said our father, whatever, is having fever and cough, and why don't we give antibiotic? He has pneumonia. Should we add antibiotic at this point? And the simple answer again is no. Why is that? Before I go to the explanation, again, I'm going to highlight certain things in this presentation. Number one, patient is having normal saturation, nothing has changed. Procalcitonin, which is an indicator for bacterial infection, very specific for the lung and the central nervous system infection, bacterial infection. So if you have a high procalcitonin, the first thing you have to think about is either the lung or the brain, central nervous system, and it's normal here. And the patient maybe is coughing or having fever from the original disease, from COVID-19. So again, studies showed that, first of all, as I said, bacterial pneumonia is uncommon with COVID infection, but you can have it in the beginning, or when you get admitted to the hospital, you might have hospital-acquired pneumonia. There's a study done and showed that overall bacterial infection rate is around 7%, 3% on admission, and 15% post-admission, hospital-acquired. Another study done in New York City, and it showed the total rate of infection, whether it's pneumonia, blood, anything, was around only 3.6%, and half it was like lung infection versus bloodstream infection, and 14% was both. So as you can see, the rate of secondary bacterial infection is very low. And the bottom line, if you have a normal procalcitonin, as I said, on admission below 0.5, then the risk of bacterial co-infection is very low. Less than, so if more than 0.5, the risk is high. And during hospital stay, as I said, you might get hospital-acquired infection, hospital-acquired pneumonia. So if you have someone has been there for 3 days and more, it's the time to think about hospital-acquired infection, pneumonia. And if he has new chest X-ray changes, if he has elevated procalcitonin, and for patient during hospital stay, maybe you have to be more vigilant, and the threshold is a little bit low. So procalcitonin more than 0.25 must open your eye that there might be an infection, a bacterial infection in the lung, and be ready to start antibiotic. And again, the guidelines, the UA guidelines says you do not have to start empirical antibiotic with every single COVID-19 patient unless clinically indicated, as I mentioned before, or you have unstable patient. If you have a patient with severe pneumonia, unstable, no one will fault you if you start empirical broad spectrum antibiotic because this patient is septic. Okay, no time to check and wait. This is not an option here. We have to start broad spectrum antibiotic for septic, critically ill patients. And later on, we can stop, de-escalate based on the clinical scenario we have and the labs and the cultures in our hand a few days later. Now, moving back to our patient, we are at day 5. The patient is still having fever. Now he has worsening cough. Now, instead of dry cough, he has a productive cough with yellowish sputum. We do a chest X-ray and it's showing new infiltrates. White blood cells are elevated around 15,000 with lift shift, mostly neutrophils. CRP is slightly more, and procalcitonin now is high, 1.4. You do blood and sputum cultures and they are pending. And the old cultures, by the way, the blood and sputum cultures from admission came back negative. But those are new cultures we did because the patient is having changes in his cough characteristics and he has a new chest X-ray findings. So the question, with those changes, we are in day 5. We have worsening cough, and now it's productive cough with yellowish sputum. We're having a new infiltrates in the chest X-ray. We have worsening leukocytosis with left shift, and procalcitonin is high, 1.4. And I said here normal is less than 0.5. But again, if you have a patient who's been in the hospital for more than 3 days, even 0.25, it's okay to start antibiotic at this point. So which antibiotic do you think we should start? Ceftriaxone, vancomycin, ceftazidime, or moxifloxacillin, or no antibiotics? And the correct answer is ceftazidime. Why I picked ceftazidime? This is hospital-acquired infection, correct? And awaiting for the sputum culture. In our region, gram-negatives and including Pseudomonas are big factors on hospital-acquired pneumonia. If you are in USA and you develop hospital-acquired pneumonia, you should cover for both gram-negative, mainly Pseudomonas, and methicillin-resistant Staph aureus. Back there, maybe you have to start ceftazidime and vancomycin, or ceftazidime and linezolid. But in this patient, maybe with the platelets are low, don't go for linezolid. So here we're covering only for for gram-negatives, mainly Pseudomonas, thinking this is hospital-acquired infection, awaiting for cultures, pending cultures. Where at day 6, your patient is having watery diarrhea. You start antibiotic, and next day, non-stop watery diarrhea. No abdominal pain, and his fever is better. What's your next step? Should you change the oral favipiravir and Camostat to intravenous remdesivir? Start oral vancomycin for Clostridium difficile treatment, or continue the same, no change? And the simple answer is change to IV. Why is that? You know, once you start diarrhea, you're not sure about your oral antibiotics or oral antivirus you're giving, whether it's fully absorbed or not. But most likely with severe diarrhea, the absorption is impaired. And the level of those medications you're giving orally will not reach the target you need to tackle whatever infection you are fighting. So my advice for your patients with GI symptoms, even if this persistent vomiting or persistent diarrhea, as this case, just change to IV till symptoms are better. We are at day 8, and the patient is having now increased shortness of breath. Cough is better, and the sputum is more whitish than yellowish, but he's feeling tired and he's tachypnic. His respiratory rate is 23, and his blood pressure is getting down. It's 109/68. And for someone who is hypertensive, this should alert you that this is not good. His heart rate is slightly high, 88. And the main thing is oxygen saturation. Now it's down to 91% on room air. And we do a CT scan to evaluate. And to the right side, as you can see, this is the old CT scan we saw in the beginning. And the left one is the new CT scan. And there is a dramatic change. And the radiologists read it as increased ground glass obesities. And now the severity score in this patient is moderate to severe. Remember, it was mild, now it's moderate to severe. So again, we're in day 8. And remember, we said your hyperimmune phase starts after day 8. Remember in the beginning, the first slide, and you can see there's increased shortness of breath, there's low oxygen saturation, there is new changes, more changes, and the CT scan, patient is getting worse. What's your next step right now? And again, easily, it is steroids. Now, steroids is a must. It is a must. And based on the study we have, the recovery trial we had in England, we know dexamethasone is the drug of choice. 6 milligrams intravenously or oral daily for 10 days. Or if you have no DIXA in your hospital, you can give equivalent steroids, methylprednisolone, prednisone, that equal the amount you give as dexamethasone. So we're going back to recovery trial. And again, to the right side, you see if you give steroids to someone early in the disease with no oxygen desaturation, someone who has normal oxygen and not in shortness of breath, you do harm more than good. The mortality rate is higher. The opposite, when you have someone who's needing oxygen, then the mortality is less. And if you have someone who is on invasive mechanical ventilation, this is when you get the most benefit from dexamethasone. As you can see, the death percentage on someone on ventilation, mechanical ventilation, is way less when you use steroids versus the usual treatment or standard of care. So going back to recovery trial, this trial showed that the patient who is hospitalized with COVID-19, when you use dexamethasone, there is the mortality rate around 28 days will be lower if you need oxygen or you need respiratory support, but not if you don't need oxygen. When you use steroids, you have to pay attention to the following. If you don't have dexamethasone, you can use equivalent steroids. Also, you should monitor glucose and secondary infection. Again, if you have someone with TB and you give steroids, and it might get worse. Latent TB, herpes, you have latent herpes, you have controlled hepatitis B infection. All those latent infection might get activated when you decrease the immune system. Dexamethasone is a moderate inducer. It might decrease the level of some medications, especially in certain conditions. A transplant patient who's on certain medication, you don't want them to be down. You don't want, although an immune system will be less and less, but we don't want also secondary infection to jump up, or a seizure patient, a patient on anti-epileptic medications. Now let's move to the second case. This is a 77-year-old male patient with a lot of comorbidities. He has diabetes mellitus, hypertension, COPD, obesity with BMI of 39, and coronary artery disease, diagnosed with COVID-19 infection. This patient has been having fever and cough with yellowish sputum for 3 days, admitted to your hospital now. His blood pressure is borderline, again, for someone who has hypertension, 103/60. He's tachycardic, tachypneic, febrile, around 38.6. Saturation is low on room air, 90% only. Labs showing elevated white blood cells with elevated neutrophils. Platelets are low. CRB is elevated. LDH, all those inflammatory markers, LDH, ferritin, and D-dimers are elevated. Procalcitonin, blood and sputum cultures are all still pending. His chest X-ray showed bilateral patches suggestive of pneumonia, and the CT scan is showing multifocal areas of ground glass shadowing, and the scoring was severe pneumonia. Before we go to the next question, there was a nice article in the Lancet, and they checked what laboratory laboratory readings that predict poor prognosis in COVID-19 patients. And they found that if you had decreased absolute lymphocyte count, this is a poor prognosis indicator, elevated CPK, CRP, ferritin, D-dimers, LDH, or troponin. If you have low platelets, if you have elevated liver enzymes 5 times more than the normal limit, and if you have acute kidney injury, all these parameters, if they are elevated, or if you have low absolute lymphocyte count or low platelets, those are poor prognostic factors. So this patient has many of them, as you can see. If you go back to the presentation, look at them, many very poor prognostic factors. So let's go to the first question. Should we give antiviral? The answer is yes. This patient has been having symptoms for, according to him, I don't know, 3 days, correct? So we're still in the viral replication phase, or theoretically we still. So remdesivir or favipiravir with Camostat. And I believe the best thing when you have high-risk patient with multiple comorbidities, with critical presentation like this, to start IV remdesivir, and you can add Camostat to it. It's better than to start oral favipiravir. Always pick remdesivir if you have it. If you don't, you can use oral favipiravir with Camostat. And again, the FDA approved remdesivir even if you suspect a case of COVID-19 before laboratory confirmation. You have to evaluate the GFR and the liver enzyme before you start. All of us know that the loading dose is 200 in the first day, then the next day is 100 once a day. Usually we treat for 5 days, but in severe cases, ICU cases, intubated cases, it's better to extend it to 10 days. If you have patient not responding to the 5 days regimen, it's okay to expand it to 10 days. And again, the most benefit we get from remdesivir when you have a moderate disease, not mild, not severe on mechanical ventilation. So as you can see in the lower left, when you require oxygen but not invasive oxygenation, you get the most benefit from remdesivir. The benefit will be minimum if you have a severe case. You remember the recovery trial showed that remdesivir is not efficacious. And I believe because a lot of those cases were moderate to severe, they did not have a lot of mild to moderate cases. And that's why the total conclusion was it's not beneficial. Again, when you give remdesivir, young people below the age of between 18 to 40 will get the most benefit of it. And if you have symptoms less than 10 days, which makes sense because when you have symptoms for less than 10 days, you are in the viral replication phase when antivirals can help. Also, when you have patient on oxygen but not receiving invasive oxygenation, you get the most benefit. You see the red arrow where it says remdesivir better than placebo. And when you have you can get some benefit also when you're not on oxygenation, but the most you get when you start using oxygen. The next question for that patient, should we use steroids? And it's no-brainer. Simple question, simple answer. Of course, yes, because saturation is below 94%. Okay, so what to give? Should we give antibiotic? The answer is yes. As you know, this is a severe case. Patient has infiltrates and his vitals are not stable. As per the even national guidelines, it's better to start for severe cases broad spectrum antibiotic, and later on you can de-escalate. In this patient, maybe if you want, I can start piperacillin tazobactam, and if you want to add something for atypical like azithromycin, you can do that. And later on, of course, based on the cultures and the clinical condition, you can stop or de-escalate. On day 2, your patient is doing relatively okay. Saturation is 92% on 3 liters. Afebrile, interleukin 6 is 30, and Brocal is 0.5. Bloods and sputum cultures are still pending. Day 4, he deteriorated. Saturation is now down to 83% on 9 liters of oxygen. He's He's febrile, but low temperature 37.7, and his blood pressure is borderline. Lab showing an elevated interleukin-6 around 350. Remember, the 1 day before, 2 days before, the interleukin-6 was 30. And now interleukin-6 is 350. We're already giving remdesivir, dexamethasone, and antibiotics. Anything else to add? And the answer is yes. We can add tocilizumab, which is interleukin-6 inhibitor. The rationale behind that when you have elevated inflammatory cytokines, including interleukin-6, you will have increased mortality and most likely from ARDS. And in COVID patients with elevated interleukin-6 and in other inflammatory markers, they most likely they are having cytokine storm. And we know that tocilizumab before helped in the treatment of cytokine storm when we give certain cancer medications. So why not use it for the cytokine storm in COVID-19? And it worked. So usually we give tocilizumab in combination with steroids, never give it alone, never ever. And you should avoid it in patients with severe immunocompromised condition, or they have risk for gastrointestinal perforation, very elevated liver enzymes, 5 times normal of ALT, uncontrolled serious bacterial, fungal, or non-SARS-CoV-2 infection, viral infection, if they have low platelets below 50,000 or absolute neutrophils count less than 50. And the study showed that if you give tocilizumab in the right time, you prevent mechanical ventilation and death. And even if you are intubated, if you're intubated and you give tocilizumab, studies show the survival is better when you give tocilizumab versus no tocilizumab, only steroids and standard of care. Also, the study showed also that tocilizumab improved outcome when you have serious condition. Now let's go to monoclonal antibodies. Monoclonal antibodies, it's an antibody that we get it from a patient who recovered from COVID, and we clone it in the lab. So if he has, let's say, 10,000, 50,000 antibodies, or let's say 100,000, we clone it to millions, and we give it to patients with acute COVID again. And going back to the first slide I showed you, monoclonal antibody should be beneficial in the viral replication phase, the first 10 days. As we mentioned, in the US, it's been given as an outpatient for high-risk patients. So if you have an acute COVID presentation, which is mild to moderate only, not severe again, mild to moderate, early, you can give it to high-risk patients. And when we say high-risk, obese patients, more than BMI more than 35, chronic kidney disease or diabetes, immunosuppressive disease, or on immunosuppressive therapy, or at age of 65. One of these, only one of them or more is enough to think about it. But I don't know if we can give it in our hospitals as an outpatient. We are trying to do it as much as we can. Also, if you have a patient who is 55 years old and above, but has one of the following, at least one or more of the following, he has cardiac problem, hypertension, COPD, or chronic respiratory disease, then you consider also monoclonal antibodies. And again, why we don't use it on hospitalized patient? Because some studies showed in the US that if you give it to a hospitalized patient, it might not be beneficial. And why is that? In the US, they don't hospitalize you unless you are sick, unless you have like moderate to severe disease. No hospitalization for mild disease. So if you give it to the patient already admitted, means those patients are moderate to severe disease. And of course, any patient who passed the 10 days period, the viral replication phase, will not get any benefit from those antibodies. And we have two kinds of monoclonal antibodies, bamlanivimab and etesevimab by Lilly. And we have also carcilimab and mdvimab from Regeneron. And those should be given in combination. And by the way, in Abu Dhabi, we have only bamlanivimab alone. And the new guidelines say do not give it alone. It's not beneficial anymore with the new strains. Convalescent plasma, we give a plasma from someone who recovered from the disease, from COVID-19, to someone with the same blood type. So we require blood type matching. And usually you should give it early, the first 3 days, and you give it with the plasma that has a very high antibodies against SARS-CoV-2. So you have to pick the highest titers to get the most beneficial. Although there is a meta-analysis revision or study done and published at JAMA recently showed no benefit. Thank you very much. I'm ready for any question.
Okay. Can you hear my voice, Dr. Jihad?
Yes,
Sorry,
yes, we do. Yes, we do.
Yeah. Sorry, I had some interruption in the introduction. So I'd like to thank you for being with us again and again. It was very rich and useful session. So now I'll move to the Q&A. And I will ask the audience to try to keep the questions around the COVID management and medications. So we have the first question. What if the monoclonal antibodies are not available? What's the standard treatment for an outpatient management of COVID patient?
Well, if you have a mild case and no risk factors, no comorbidities, and you want to send that patient to a hotel, home, the only options we have is the following: just PO oral antiviral. So we have the favipiravir and the Camostat, and sometimes we give vitamins with it, C, D, and zinc. These are the options we have.
Okay. So we have another question asking about ivermectin, the antifungal, or the ivermectin as a prophylaxis. Is it beneficial?
Okay.
Any studies that recommended it?
Yeah, there is multiple randomized studies are going on to evaluate ivermectin. And ivermectin, you know, it's an anti-parasite medication. And it showed some success in certain Bangladesh, India. In the US, still under study. And the IDSA guideline and NIH said, do not use it unless it's a part of a study. So the bottom line, we're still waiting for the final results. And the national guidelines says it doesn't recommend using it here in UAE.
Okay. We have another question asking about giving dexamethasone for 3 weeks. Is it beneficial, or would you just stick to 10 days regimen?
Only 10 days. I've seen cases in the ICU when they require more than 10 days. Usually we give it to another 4 or 5 more days, up to 2 weeks. But as an outpatient and patients improving, no need.
Okay. So I have one question related to the steroids. So if the steroids can increase the risk of infection and cause suppression of the immune system, how would we know whether this choice would cause like more harm or benefits for our patients?
Based on the studies we had, the recovery study showed that the benefit overweighs risk. So yes, there is a risk for secondary activation of latent infection, as I mentioned, maybe herpes, maybe hepatitis B, maybe latent TB, but the benefit is way more than the risk. based on the study they did and the rate of secondary infection versus the success rate in saving lives, they decide, give it.
Okay. On mechanically ventilated patient with no improvement, is it helpful to give interleukin-6 medications?
Yes, it's indicated, and as you can see in this, can you see my screen?
Yes, we can. Yeah.
Yeah, so this is for ventilated patients. And as you can see, it saved life. It improved mortality.
Okay. Okay. So what's the role of azithromycin or clarithromycin in the management of COVID patients?
It has no role at all, period.
Okay.
Unless you're treating secondary infection from the beginning, and I told you, you have to look at the patient stable, unstable, chest X-ray suggestive of secondary bacterial infection, procalcitonin is high, all these markers. You can use it to cover for atypical bacteria with another medicine, ceftriaxone, for example.
Okay, this is very interesting question. If the patient is going for surgery with anesthesia, what will be the best treatment option? I think they are not talking about elective surgeries. Should be like an emergency surgery.
You mean treatment for COVID?
For COVID, like COVID patients.
Yeah, I think you have to continue this at least if the case is severe. Of course, first of all, we have to use IV. So remdesivir will be a good choice, and IV steroids.
Okay.
Those are, if the patient is entitled to get steroids, if he had low saturation. If not, remdesivir alone IV.
Okay. So just going to another related question to remdesivir. So apart from severe pneumonia with oxygen need, when would you consider switching from oral options like Fabi and Camostat to remdesivir?
Yes, I did that, and usually we do it in our hospital. If you have a patient who's been on oral antiviral, favipiravir and Camostat, and after 3 days, no improvement, and the patient is having multiple comorbidities, we switch to IV remdesivir. Patient is old, having diabetes, cardiac problem, kidney, liver, all those high risk, then we switch. Patient from the beginning, high risk patient with moderate to severe case of COVID, from the beginning we use remdesivir. So high risk with moderate to severe case, use remdesivir from the beginning.
Okay. So are there any studies on molnupiravir, which is a new drug manufactured by Pfizer?
Not yet. I don't know about it, to be honest.
Do swab pick up all variants, like the PCR swab?
No, you have to do genesequencing. So usually, just for the research purpose, you do gene sequencing for the positive samples you have. But swab should tell you just positive or negative, doesn't tell you what variant. You have to do gene sequencing, which is a sophisticated test done in certain labs.
Okay. What about inhalational options of treatment for COVID patients?
Yeah, there's you can consider. I didn't put it in my note because I don't use it, and it's optional, like or not very strong recommendation.
The interferon?
Yeah, interferon, inhalation of interferon, and I haven't used it in our hospital, to be honest, but it's in the national guidelines.
Okay.
And it's not, by the way, it's not anywhere in the IDSA guideline or NIH guidelines at all. So that's why I don't know about it.
Okay. Okay. So what about giving favipiravir for a pregnant patient?
Big contraindication. You cannot give it. Completely contraindication. Never ever. It's teratogenic.
Okay. So what's the role of antimalarial medications in COVID management?
Okay. So, this is like the ivermectin and other medication and maybe colchicine. If there's a good study that from the beginning used it for early stages of the disease, the first few days when you have the viral replication phase and compare it to placebo, that would be great. But you know, they used it for moderate to severe cases. All those trials you saw used it for moderate to severe case with few mild cases. And the results came as not beneficial. And on top of that, they used high dose. So there was some cardiac problem, prolongation of QT interval, and it was killed in the bed. So no more.
Okay. What will be the best treatment options for pregnant patients? If we are not going to give favipiravir, what other safe option would you consider?
Now, we used to give HIV medication, which is called Kaletra, but it's not efficacious anymore, and we don't give it. So if you have to do something, then remdesivir can be used.
Even for like asymptomatic or very mild cases,
Asymptomatic,
right?
we don't, no. Asymptomatic, we follow. Asymptomatic, we don't treat, we follow. Only when you have pneumonia and patient is having progressed disease.
Okay. How would you manage patients with elevated LFT? Like which medications of COVID medications are the most hepatotoxic ones?
Favipiravir and Camostat, both of them can give you elevated liver enzymes, and remdesivir can do, but to less extent. So if I have someone with elevated liver enzymes and and he's on favipiravir and Camostat, I'll switch to remdesivir, and we can carry on until it's 5 times normal, then we can stop.
So even if you had mild elevation of LFT, so when did you switch? Yeah. If 5 upper normal, then you will switch to remdesivir, or if you have mild elevation, you will switch immediately.
Because it will keep increasing fast if you use Favi. So if it is double or triple, I'll change to remdesivir, because we have a space then up to 5 times normal.
Okay. So I would say the answer, remdesivir is the least hepatotoxic, one of the options we have.
Yes.
Okay. How would you manage patients with the hematologic manifestations? You know, leukopenia, anemia, thrombocytopenia. These features are very, very common in patients with COVID. So which medication you will stop and when?
Yes. So number one, certain medication we cannot use if you have severe leukopenia and severe thrombocytopenia. For example, as a monoclonal antibody, tocilizumab, we cannot use. And you can use with caution for favipiravir and Camostat. For remdesivir, also you can use, no problem. But if you develop that and patient is okay, no fever, so you don't have neutropenic fever.
Right.
Yeah, you can carry on and push the patient till you reach 5 days of, let's say, remdesivir, and patient improves, or 7 days of Favi. If you have thrombocytopenia and patient is not bleeding and it's not severe, we're okay. But if it gets really severe down to less than 20,000s, be careful. And you know, this thrombocytopenia is from the disease itself, from COVID, you know, and it's one of the poor prognostic measures. Like if you have severe thrombocytopenia, it's a poor prognosis. Then we can transfuse platelets. What can you do to prevent further, like especially if the patient has spontaneous bleed? And by the way, spontaneous bleeding will not happen even if you reach 20,000, way below that.
Okay, now this is for the low platelets, but what about the anemia and the leukopenia? Would you stop favipiravir or Camostat if you had any hematological manifestations?
If it is very low, I would stop and observe and change to different medication. Again, remdesivir would be a good choice then. Okay. And I would recommend consulting hematology, because they might give some kind of medication to bring up your white blood cells.
Yeah, like the filgrastim. Yeah.
Yes.
What about adding Camostat to remdesivir regimen? Would you recommend that?
We do that. We do
Okay,
that.
so what are the indications?
Yeah. Well, usually, if you have a moderate to severe case, we start remdesivir with Camostat, both.
Okay.
But never do favipiravir and remdesivir, the same mode of action. You're not going to add anything.
Okay, okay, I see. How would you treat breastfeeding COVID patients?
Okay, usually, I have to think about this. I have to go back to the brochure. Like, I'm not sure about this, to be honest. I'm not going to answer something out of my head. I have to go back.
Yeah, I'm sure we can check with the clinical pharmacy. We know about the expiration in the milk. But, if the mother can stop breastfeeding for a few days, that will be, of course, the safest option until she completes the treatment.
Yeah.
But we can always check with the clinical pharmacy.
Yes, that's what I do. I'm not sure about this question.
Yeah. So after completing 5 days of remdesivir, any recommendation to continue? Because if you want to discharge the patient, you will not discharge on IV option. So if you complete 5 days, patient stabilize, would you switch to other oral options?
If the patient has improved and he's okay, 5 days is enough. If not, and patient insists on be discharged but still having symptoms, and usually we don't send patients home who are still on oxygen or sick, but suppose there's something, we switch to favipiravir.
What about COVID patients with ICH? Would you recommend antiviral? I think ICH is the intracranial hemorrhage, right?
Yeah,
So would you recommend antiviral medications in those cases?
I did not see any contraindication for Fabi with intracranial hemorrhage or even remdesivir. And I have to go back and check. Not to my knowledge, it's a contraindication. But I have to.
Sure. Is there any specific drug which can induce skin lesions related to COVID?
COVID itself can give you different kind of skin lesions, skin manifestation. Then if you have allergy from any of the medications we're giving, any medicine can give you allergic reaction and skin rash or lesion, and we don't know till you get it. So either you can get the skin manifestation from the disease itself or as an allergic reaction to one of the medication you give for the treatment. But as specific skin lesion for specific drug, the answer is no, unless you have allergy to it.
Okay. Any benefit of colchicine as anti-inflammatory drug in COVID patients?
This is the same thing as ivermectin. We need randomized studies to check the efficacy of this medication, well-controlled randomized studies, placebo versus colchicine, and we'll see. And there's a couple of studies going on, and we'll wait, but we don't have a conclusion yet.
Okay. So if you have patient or post-COVID-19 lung fibrosis patient, what will be like the best optimal treatment? Would you consider oral steroids for longer period in such cases?
So this is like, this lung stiffness and maybe early fibrosis. We've seen it in severe cases of COVID-19 patient who've been on ventilator, recovered, had a prolonged hospital course. And those patients, what they need is just time and physical therapy. And some of them will need up to 6 months to get near what he was before. So no specific drugs, just time and physical therapy. But drug, like a magical bullet, a magical drug, no, it's nothing.
What's the role of omalizumab in addition to management of COVID-19? I think the omalizumab is the anti-IgE drug. Were there any trials on this medication to treat COVID patients?
Not to my knowledge. I don't know about it.
Okay, so I received many questions about anticoagulation. Maybe I will keep it to the next.
Next.
Yeah. Okay. Fiber lactic in COVID patient. Have you come across fiber lactic? I'm not familiar with it. Okay. When would you add aspirin to the management of COVID
I'll keep this
patients?
to the next session.
Okay. Okay. Uh, okay. How early does COVID lung fibrosis develop?
Usually, it's only for severe cases, prolonged hospital course, and at least a couple of weeks. I haven't seen one with lung fibrosis the first week or two. It needs more than that.
Okay.
And you have to have multiple comorbidities, baseline lung problem.
I see. So can we stop steroids after 10 days of treatment, even if the patient requirement of oxygen was high? So I think the question is saying if the patient complete the cortisol regimen, whether it's 10 or 14 days, and the patient is still requiring oxygen, would you still continue the steroid?
Usually I extend it up to 2 weeks. Beyond that, I haven't seen any benefit. 2 weeks max.
Okay, great. Dr. Jad, thank you very much for this session. So now I will move to the next segment. We will have Dr. Nias talk about antithrombotic treatment in COVID patients. Dr. Nias, please, you have the mic now.
Yeah. Thank you very much, Dr. Umar and Dr. Jihad, for a very nice presentation as well as the discussions. And I would like to thank Sanofi for inviting me to give this talk. And Dr. Jihad spoke mainly about, let me share my screen.
Yeah, until you share your screen, I just want to indicate that this session is not this coming session, antithrombotic therapy in COVID-19, is not CME accredited. It's just symposium organized by the sponsoring company. Okay, Dr. Niaz, go ahead.
Okay,
please.
yeah, so Dr. Jihad mainly spoke about the specific antiviral therapies, but I will be discussing about another important aspect of the management of the patients having COVID-19, that is the antithrombotic therapy in COVID-19. The outline of my talk will be, first of all.
Can you make, please, your presentation full screen, please?
It's not full screen? Okay. Yes, okay.
Yes, thank you.
Yes, now it's
Okay.
better. Thank you.
Yeah,
Yes.
so I'll be speaking briefly about the pathogenesis of COVID-19 coagulopathy to understand the mechanisms, and then briefly touch upon the incidence and prevalence of the VT in COVID-19 patients. And I will be just reviewing what we are doing related to our current practices regarding the VT prevention and treatment. And lastly, but importantly, I'll be discussing, rather mentioning very important new recommendations from the American Society of Hematology and National Institute of Health, which were published, I think, in about 4 to 6 weeks back. Now, we all know that the SARS or coronavirus has got a spike glycoproteins, and which they bind to the AC2 receptors, and then they are internalized, leading to the high accumulation of angiotensin 2 type 1 receptors, which has got its own mechanisms. Now, these AC2 receptors, they are present in most cells of the body, particularly in the pulmonary, pulmonary parenchyma. We have got them in intestines, in brain, and vascular endothelium. So therefore, we nowadays, COVID-19 is being considered as a multi-system disease because it has manifestations all over, involving all the systems of the body. Now, if we see just very briefly, basically, similarly, just like ACE2 inhibitors, ACE2 receptors, they are present in the vascular endothelial cells also. So once these vascular endothelial cells are infected by this coronavirus, What does it do? It does two things. First of all, it causes inflammation of the endothelial cells, what we call is a COVID endotheliitis. Now, this causes the release of a pro-inflammatory mediators, including various cytokines and chemokines, IL-6, IL-8. At the same time, the another endothelial injury, this causes what we call the COVID-19 coagulopathy, which this leads affecting the mucosa of the vascular endothelium, and where the platelet then come and start the cascade of coagulation. Now, both these mechanisms, endotheliitis and coagulopathy, they enhance each other, and which in fact leads the end consequences is that COVID-19 pneumonitis, which is in fact combination of a both endotheliitis as well as a coagulopathy, which what we had. So if there's a cytokine storm, now this primary initial endothelial injury can be enhanced once there's a cytokine storm and what we call is a secondary endothelial dysfunction. Now, the COVID-19, basically, I discussed about the endothelial dysfunction being caused by the COVID, but it also affects the other two important steps or the elements of a Virchow's triad of coagulopathy. Endothelial dysfunction, as I mentioned, causes causing the coagulopathy and as well as causing the hypoxia, and then cytokine storm, which causes the release of various TNF, as I mentioned. So it is an inflammatory state. And we all know that all inflammatory states, they are causing the hypercoagulability. So endothelial dysfunction and hypercoagulability, they complete the, and then Virchow's triad is completed by a lot of these patients. When we all know the COVID-19 patients, they may be immobilized because of the isolation or because of the quarantine or because they are so sick. So immobility contributes to the development of the coagulopathy. And sometimes the cardiac muscle is also involved. Left ventricular dysfunction and myocarditis is also a part of the manifestation of the COVID. So all these three elements of a Virchow's triad are contributing to the increased coagulopathy in COVID-19 infections. Now, earlier last year at the beginning of the pandemic, some people, I think it was in European countries, Spain, they were able to biopsy some of the, do the postmortem and do the biopsy of the pulmonary parenchyma. And they surprisingly found that these patients, they had a microthrombi in smaller pulmonary arteries and arterioles. That was quite at the beginning of the pandemic. Now, in fact, then at the same time, there was a study from Wuhan, which mentioned, or which a retrospective analysis that showed that mortality of the patients was much correlated directly to the level of D-dimers. Higher the D-dimer levels, the higher was the mortality. And those patients who had D-dimer levels of less than 0.5, their survival was much, much better as compared to those patients whose D-dimers was high. And this was also clinically correlated, clinically and radiologically correlated. Now, D-dimer levels, they were found to be in those patients who had a mild infiltrations of the lung parenchyma on CT scan, their D-dimer levels have only 2 to 3 times higher. But those patients who had a severe COVID disease with whole lung nearly being infiltrated by the infiltrates and by the COVID white lungs, the D-dimer levels were higher. So D-dimer level were proportionately higher in those patients who had a higher involvement of the pulmonary parenchyma. So these two things really alerted the scientific community, and then everyone started talking about hypercoagulability as an important clinical feature of COVID-19 infections. Now, this coagulopathy, which I've been talking, is a little bit different from the routine coagulopathy, which we see in other inflammatory conditions like influenza and even the MERS and other coronaviruses documented before. First of all, we noticed that in these patients, the hypoxia in these patients was quite out of proportion to the involvement of the pulmonary parenchyma as seen by the CT scan. And then there was, as I mentioned, there was a lot of microvascular thrombosis and hemorrhages were noted in these patients. And that is, in fact, is a feature of a macrophage activation syndrome. So these were the two atypical things which differentiate this coagulopathy from the other coagulopathies associated with other viral infections. Then we found that these patients, they have got increased tissue factor, which is localized to thrombin generation, increased plasminogen activator inhibition, which leads to the decreased localized bronchoalveolar fibrinolysis. So that means there's not only coagulation, but because of this increased level of plasminogen activator, there's a decreased fibrinolysis. So whatever clots are being formed in the pulmonary parenchyma or other tissues of the body, vascular endothelium, they are not being fibrinolized. And then we all know the contribution of the cytokine storm, which can cause itself alone activate the coagulation cascade and leads to a picture of a DIC. So therefore, the term came pulmonary intravascular coagulopathy to differentiate it from the disseminated intravascular coagulation, which we see in all, as I mentioned, other viral and other septic conditions. Now, this pulmonary intravascular coagulopathy is differentiated by two important things. Of course, it is one that in the fibrinogen levels are normal in these patients, and platelet levels are also at the beginning normal in many patients. Now, these are the two things which differentiated from the disseminated intravascular coagulopathy. So this was labeled or a term as a pulmonary intravascular coagulopathy. Now, this COVID-associated coagulopathy, now about 20% of these patients, whoever are being admitted, they have got coagulation abnormalities. But if the patient is, but this coagulation abnormalities, they are being seen in all the patients who have got a severe and critical illness. At the same time, we started noticing that these patients, they have got unexplained death, and which was later on found to be most probably due to the pulmonary embolisms. And we found that these patients are at very high risk of hospital-associated VTE as early as 2020 in the March beginning. But the general the consensus is that the possibly VTE, conventional VTE, it still remains underdiagnosed in patients with severe COVID disease. Now, not only the venous thrombosis, but arterial thrombosis have been noticed in these patients present. So these patients, they can present with acute myocardial infarction, they may present with acute ischemia of the gut, or they may present with acute ischemic stroke, or they may present with acute limb ischemia. And then the thrombotic events were also noted in those patients who were requiring renal replacement through dialysis catheters and as well as the ECMO catheters. So this is a generalized generalized coagulopathy was noticed both in the venous as well as in the arterial circulation. What is the incidence? Now, the incidence recently, it's about 2-3 weeks back, it was mentioned. Overall, there was an interesting meta-analysis of all these studies, and it suggested that there's about 17% overall incidence of VTE among COVID-19 patients who are being admitted. Of course, the incidence varies between the design of the study and the method of the assessment. The incidence is much more, rather 4 times higher in those patients who are admitted in ICU as compared to non-ICU patients. You can see 28% prevalence in ICU patients as compared to 7%. Incidence is also this, the overall incidence and prevalence depends upon how much you are investigating. Some centers, they were able to do routine ultrasound for all the COVID-19 patients, which is really logistically not possible nowadays. And they found that the overall incidence of VT prevalence was 40% in those where the ultrasound was done as a routine, as compared to 9% in those centers where ultrasound was not being done. And so incidence really has got much more variation depending upon how much keen you are in investigating, looking for this VT events. As I mentioned before, that it is not only the microangiopathy, but there's a macroangiopathy, a macrovascular thrombosis, ischemic stroke, myocardial infarction, as I mentioned, clotting of the extracorporeal circuits, mesoneal ischemia, leg ischemia. And in fact, there was a small cohort of a study from our hospital. I was part of that thing that was published last year. We presented a series of 24 patients who presented with acute ischemic stroke as a presenting feature. The majority of these patients, they were younger people, younger than 55, and about 1/3 of these patients, they didn't have any conventional risk factors like diabetes or hypertension or smoking. Okay, and then interestingly, those patients and 80% of these patients who had normal chest X-rays, And 8% of them, I think, one third of these patients, they developed pneumonia while during the hospitalization. So their first presentation was acute ischemic stroke, and the pneumonia followed these things. Now this is being well documented in many other studies worldwide, and ischemic strokes are, now there was a discussion about the ICH. In fact, in our hospital, we have seen patients presenting with ICH also, the first manifestation, but it is very difficult to attribute COVID-19 directly to the cause of ICH. But presentation as a ischemic stroke is more logical to attribute it to the coagulopathy related to the COVID-19 infections. Now, so as part of our discussion today, so what we should do and what we have been doing so far related to this thrombotic problems in our patients. Normally, first of all, as a routine practices, so we should do the risk assessment. Now, risk assessment, you know, all the hospitalized patients are being assessed for the VT risk factor routinely, even non-COVID patients. And medical patients, there are some risk assessment models are there, like PADOA scoring system and improved risk assessment models for medical patients, and Caprini-RAM for surgical patients. Now, they have got risk factors, and then according to the scoring systems will determine how much patient is being at risk of developing VT during the course of the hospitalizations. Okay, and now, so therefore, these COVID patients should not be different. They should also have the risk assessment, although I believe that majority of the COVID-19 patients, they will have a high risk of developing VT because of just being hospitalized. Because according to the PADOA scoring system, anybody who is hospitalized for more than 3 years or so more than 3 days of a hospitalization is considered as an immobilization, and immobilization itself is a risk factor for a VT. So therefore, these patients, they need to be given thromboprophylaxis. So therefore, we should all really do these things, but I'm not really very sure whether we have got enough time to go for these things, but definitely the risk assessment has to be done in all these patients. Even in those patients who are not being admitted, those patients coming in, outpatients are coming for a first visit and they are being discharged from the emergencies. Even these patients, they should be also assessed for whether they've got any high risk of developing VT or not. Once the patients, they are hospitalized, the risk assessment, you know, their patient's profile may change. The patient's illness itself may change. Patient may require further medications. Patients may require some invasive procedures. Laboratory parameters might have to change. So therefore, risk has to be really evaluated on daily basis. And of course, if the patient is, as I mentioned, requires an ICU care or requires high oxygen requirement, this is an additional high risk for a developing VT. So therefore, after the first step of assessing all these patients, second thing is, so let us see what we can do to prevent VT in these patients. As a general principle, we all know that in prevention, avoid sedentary. Now, this is really not possible because these patients are being isolated either in a small room or in a particular bed. So perhaps they cannot be mobilized except maybe to the toilet if they got a single bedroom, single room available. Otherwise, but the other things I would suggest sometimes is the regular exercises in the bed while the patient is being lying down. Still, he can do the limb exercises, ankle, the ankle pump movements. They can do even routinely. We advise by patients to do these routinely, even they are on pharmacological prophylaxis. Still, we encourage them. They have to be encouraged to have more water. Of course, we have to avoid dehydration. And if there's any volume loss like vomiting and diarrhea, then you have to replace their things. But if the patient has got a high or moderate risk as determined by your risk assessment model scoring, then pharmacological prevention has to be prescribed. And if you talk of pharmacological prevention, most of these patients, most of the places worldwide, low molecular weight heparin is being considered as the first line treatment for prophylaxis in most of the cases, most of the places, if there's no obvious contraindication. If the person has got a high risk of bleeding, which you can assess also somebody having a very low platelet count, somebody having a very deranged liver functions with very high INR and PT, PTT, or previous history of bleeding disorders, then perhaps these people are candidate for mechanical prophylaxis, what we call the intermediate pneumatic compression. if the patient has got a low risk of bleeding, okay, then we still give them a pharmacological prevention, and if there's no contraindication to other antithrombotic drugs. However, the patients having renal impairment, when the creatinine, creatinine, or GFR is less than 30, we prefer unfractionated heparin, although there's a logistical problem with unfractionated heparin as compared to the low molecular heparin, because you need to monitor frequently PT, PTD, which may not be possible to avoid in the patient having COVID infection because of reason not to expose the healthcare personnel to take the blood samples frequently. In case of thrombocytopenia, if it is less than 50,000 platelet count, and if there is suspicion of a heparin-induced thrombocytopenia, non-heparin anticoagulants can be given as a prophylactic agents, such as danaproid and bevalderidin, or fedoprenix sometimes can be given. What about the extended PT prophylaxis? Now, there's no data specific to COVID exists. Again, your risk assessment has to be given some importance. And if the any patients, those who are being discharged from the hospital, even after finishing the treatment of COVID treatment, their mobility may remain low because they are very elderly, they are very fragile, or because of other reasons. So sometimes it is very important to extend the VT prophylaxis for about 4 to 6 weeks, even at home. Okay. The same is applied for a quarantine patients. If you think the patient is being treated, is still at home and is not very mobile because of many different reasons, then again, patient may be given. Now, this period up to 45 days is not must for every patient. Depends upon patient situation. I mean, varying from 2 weeks, 10 days to 4 to 6 weeks is generally. I'll be discussing it, new guidelines when I'll be in my next slides. Low molecular weight heparin is preferred over directly oral anticoagulants because, as Dr. Jan mentioned, these days sometimes there's interaction between the antiviral drugs and the oral DOAX agents. So therefore, it is preferably avoided to give them or put them for DOAX is a prophylactic agents. What about the diagnosis? Now, sometimes, this was all about the prophylaxis, but what about if you are clinically suspecting patient might have developed any VT event? Now, elevated D-dimer alone does not warrant routine investigation because elevated D-dimer may have different reasons of sometimes infection itself, but just alone D-dimer does not really warrant the patient should be routinely investigated for acute VT. But because of the very high incidence of the VT, the clinician should have a low threshold, I mean, of suspecting VT if the patient develops any suggested signs and symptoms. High index of suspicion for VT if the patient develops unexplained tachycardia or hypotension, or when you think the hypoxemia is disproportionate to the lung pathology or lung findings, or if there's any right ventricular dysfunction. Now, these are the clinical suspicions where you can think the patient might have developed pulmonary embolisms, and so therefore you have to make a diagnosis on clinical grounds. Again, elevated troponin is considered to be a poor prognostic marker because it signifies that patient may have right ventricular strain. But again, elevated troponin may be due to other non-specific marker injury, sometimes even due to renal impairment. So there are multiple reasons for it. So you don't have to rely purely on the elevated troponin, but definitely people do it in many places as a prognostic marker. Elevation of BNP again is non-specific, and you cannot just make a diagnosis that someone has got high BNP, so therefore you might have developed a right ventricular strain or right ventricular, congestive heart failure because of the pulmonary event. What about the heparin? Now, heparin, as compared to, there are some advantages of heparin because not only it is anticoagulant, because its efficacy has been shown by decreasing the carotid thrombi, pulmonary emboli, and microvascular. We all know it, but it has got anti-inflammatory role also. And because it has been found to decrease the neutralizing pro-inflammatory proteins, and it can down-regulate the IL-6. And even some studies which are not very convincing, but This demonstrated that heparin may have some antiviral properties by binding to the SARS-CoV virus surface receptor binding protein, spike proteins. So therefore, they may inhibit the viral entry. So these are the proposed mechanisms, having an additional advantage why we should be using heparin in these patients with COVID. Now, what about the doses? In fact, there has been a lot of debate about the doses of heparin or a low molecular weight in patients who are being hospitalized. Okay, and then normally the recommendation is there is standard prophylactic doses. Does not the low molecular weight heparin does not significantly impair the progressive increase. So this might sometimes the our junior doctors, they are guided in that they think, okay, once we are starting the Clexane or any other low molecular weight heparin, D-dimer levels may decrease, but there's no direct effect of low molecular heparin on the D-dimer directly. And there's no evidence that increasing the dose of low molecular weight thromboprophylaxis improves clinical outcomes or reduce the risk of VT. And in fact, ACP last year, we are talking of 2020, recommended against the routine use of intermediate dose of thromboprophylaxis. Normally, you know, because last year there are so many studies were coming related to the coagulation problems in COVID patients. So people started giving the patients a subtherapeutic doses or even a therapeutic doses of a low molecular weight heparin or even other DOACs in patients who were suspected to have even as a prophylaxis, not as a treatment. But SCP in 2020 recommended against the routine use of intermediate dose. But different institutions and hospitals in different countries, they've got their own guidelines. Now, many hospitals, they adopt weight-adjusted low molecular weight prophylaxis for those patients high BMI. For example, normally we give 1 milligram per kilogram body weight as a prophylactic. We are talking of enoxaparin. But if the patient's body weight is more than 80, sometimes you have to double the dose or increase the dose. So therefore, as a weight-adjusted dose can be given as a prophylaxis in very obese patients. The D-dimer, as I mentioned before, does not really guide the management in patients. And this was telling you that there was some guidelines. In fact, even we were also following these guidelines a few months back, that when we say of a standard dose of prophylaxis, we were talking about 1 milligram per kg body weight. But then treatment dose, you have to be given very high doses according to the D-dimer levels. So those patients who had a D-dimer, so D-dimer itself was an indicator how much dose of enoxaparin or DOACs you are going to give to your patients. What about the imaging? Now, more complex and challenging in patients due to several factors, because normally we confirm the diagnosis of DVT by Dopplers, and we confirm the diagnosis of pulmonary embolism by doing a CTPA. But of course, because of the logistical reasons, risk of transmission to other patients, healthcare workers, contamination of the equipment, and patient may not be fit to be transferred to the radiology department because he's on CPAP, on high oxygen requirement, or he's on prone position. No, he's on ventilator. So therefore, and then some of the local radiological protocols may not allow the patients to have these investigations if you are really clinically suspecting any VT events. Medical therapy for these patients now, if once you confirm the diagnosis of DVT, as I mentioned, so therefore confirmation is more on your clinical acumen, clinical suspicions, and clinical findings rather than there's a radiological proof. Now, once you decided that your patient has got a confirmed VT, then of course the treatment is therapeutic anticoagulation is the mainstay of the treatment. Now, selection of the agent will require, depends upon how many comorbidities your patient might have, renal problems, might have hepatic dysfunction, what is the level of platelet, has he got any history of any GI bleeding. So these are the things which will determine which agent you want to use as a treatment for a VT event. And critical ill patients, also those who are in ICU, because their pharmacokinetics and pharmacodynamics may change on a daily basis because of the variable absorption, metabolism, and renal, they may develop acute organ dysfunction also. So therefore, a lot of considerations are required when you are choosing which anticoagulant you want to use in these patients who have developed VT events. Now, it is proposed that in ICU patients, parenteral anticoagulation, for example, like unfractionated heparin, is preferred because of the one reason that you can temporarily adjust it, because these patients, they may have a very variable parameters changing within hours, so you can easily stop or the dose of unfractionated heparin, and then of course it has no drug-to-drug interaction. But as I mentioned, it will be very difficult also sometimes because you need to achieve a good APTT, therapeutic APTT levels, and for this you need to have a frequent blood sampling, which may not be really possible because of obvious logistical reasons. What about the newer novel oral anticoagulants? Now, of course, everyone knows that benefit is that their oral route is important as compared to the parenteral, and you don't have to monitor. Then you can easily discharge the patient also, even you can manage the patients on outpatient basis also. But of course, the potential risk is there that for example, the patient may clinically deteriorate, okay, then you may not have a timely availability of an effective reversal agents at some centers because it is very expensive, and the antidotes of these drugs are not present in most of the places. For patients who are already for discharge, then either you can discharge them on drugs or you can discharge them on no molecular weight heparin would be preferred because again, to limit the contact of the patient with healthcare services, and you don't have to monitor INR. Now, coming to the last part of my topic, that is most important, is the guidelines. Now, sometimes we physicians are being confused because nearly every institution, every country has got their own guidelines, and generally the international guidelines which are being followed is by the American College of Chest Physicians, ASH, the American Society of Hematology, National Institute of Health, then International Society of Thrombosis and Hemostasis, the Royal College of Physicians NICE guidelines, European guidelines, and then we've got UA guidelines, and now that is being revised every 3 to 4 months, depending upon the availability of the new scientific evidences. Now, the last UA guidelines which we are following was revised in 18 February, and it again mentions that all patients admitted with COVID should receive pharmacological prophylaxis irrespective of VT risk. Okay, so therefore we decided that there's no need to assess the risk because, as I mentioned, technically every COVID patient is at risk of developing VT. Now, the institutional policy should be used for dosing how much heparin or enoxaparin has to be given. Now, sometimes this was being followed up. Hopefully, this will be revised now. We were following D-dimer levels also, as I mentioned, for determining giving them a higher doses. But again, as I expect that in new guidelines, this perhaps will be omitted because the international guidelines are not really in favor of D-dimer being alone as a parameter of deciding which dose of enoxaparin or anticoagulants you want to use. Now, if the patient full anticoagulation should be given only for patients with confirmed VT disease, either they have DVT or P, or if there's a high clinical suspicion is present. And there's currently no recommendation for empirically full anticoagulation outside the clinical trials, and intermittent pneumatic compression devices should be considered if there's any contraindication. And upon discharge, if clinically fit for discharge, D-dimer is high, patients to be discharged and anticoagulation for 2 to 4 weeks with reassessment after that to decide on further need. So this is what protocol we are following at the moment. So these are guidelines, including our guidelines. They agree that hospitalized patients with COVID infection should receive prophylactic dose anticoagulation. Some agree that intermediate dose may be considered for ill patients. Now, these recommendations are there. First of all, the ASH guidelines suggest that prophylactic intensity suggests that using prophylactic intensity over intermediate intensity or a therapeutic intensity anticoagulation for patients with critical illness. So this is clear now. There's no role of a intermediate dose or a therapeutic dose in patients having critical illness. What is critical illness? Critical illness is defined those who have got immediate life-threatening conditions like admission to ICU, or those who have ventilator support, or who are on renal replacement therapy. There are 3 trials. We are waiting the results. Also, some of the early results are already on the line, I think so. 3 trials, they are directly comparing the therapeutic doses versus the prophylactic doses. Is a prophylaxis in these patients. The full results are yet to be coming. The second guideline, the second recommendation from S guideline is that patients having acute illness, again, you have to use a prophylactic intensity rather than a therapeutic or intermediate. So both in acute illness and as well as critical illness, the recommendation is that you have to give a prophylactic dose of anticoagulation rather than a therapeutic dose in these cases. But the ASH acknowledges also that the risk of there has to be individualized assessment of the patient's risk of thrombosis and bleeding is important when deciding an anticoagulation. Risk assessment model being used in many places, but they have not been validated for patients with COVID-19. The selection of the specific agent will depend upon the availability, the resources required, and exposure to the stuff. Okay. And high intensity anticoagulation, sometimes we still prefer if you think that your patient is at very high risk of thrombotic and he's at very low risk of. So it has to be really individualized in certain patients. You cannot just completely not give them, because you think your patient is very high risk, you can, especially those patients who are on renal replacement therapy or an ECMO, they may require higher doses of a coagulation. The other group of guidelines lastly is by the NIH guidelines. Now, again, the recommendation, third is expert opinion. I'll show you very briefly, quickly. In non-hospitalized patients, there are currently no data to support the measurement of coagulation markers as a routine. Although abnormalities in the coagulation function have been associated with worse outcomes, prospective data are demonstrating that the markers can be used to predict the risk of VT in those patients who are asymptomatic or who have mild infection is lacking. So you can do these coagulation markers, but they are not correlated with they cannot determine whether your patient will become sick or not. In hospitalized patients, again, they are being monitored very frequently, but again, they should not be there to guide the management decisions. What about those patients who are receiving anticoagulation or antiplatelet therapies before they develop a COVID infection? They are advised to continue these medications even if the diagnosis of COVID is made. So if they are taking these aspirin, other thing, they have to continue. What about the prophylaxis in these patients? Again, anticoagulants and antiplatelet therapy should not be initiated for the prevention of VT or arterial thrombosis unless the patient has other indications. So if you think, well, we are talking of in non-hospitalized patients. If you think the patient is not at risk, perhaps may not be required. But again, this has to be individualized. Non-pregnant adults should receive prophylactic doses, and anticoagulant or antiplatelet should not be used to prevent. Mind it, this antiplatelet and anticoagulants should not be used to prevent the arterial thrombosis. They are given to prevent the venous thrombosis. And there's insufficient data currently about the thrombolytics and then about the higher doses of anticoagulation. Now, those patients, hospitalized patients should not routinely be discharged from the hospital while on VT prophylaxis unless they can continue the prophylaxis at home. This is very, very important to understand. Now, regarding continuing anticoagulation with the FDA-approved regime for extended VT prophylaxis, after hospital discharge can be considered for patients who are at low risk of bleeding and high risk of VT, as I mentioned before. So both ASH and NIH also give the same recommendation. There's insufficient data to recommend either for or against the DVT screening in COVID-19 patients. And for the hospitalized patients who experience rapid deterioration of pulmonary, cardiac, or neurological function, or a sudden localized loss of peripheral perfusion, the possibility of thromboembolic disease should always be evaluated. So if there's clinical suspicion, then you can treat him as a thromboembolic event. Which agents now, because of the potential drug-to-drug interaction, must be considered if you are selecting any particular agent. In hospitalized critically ill patients, low molecular weight heparin or unfrequent heparin is preferred over oral because, again, as I mentioned, heparin has got half-life, can be administered either IV or subcutaneously, and it has got a fewer drug-drug interactions. For the children, the recommendations are the same. What about the pregnancy and lactation? Now, if antithrombotic is prescribed during pregnancy prior to diagnosis, this therapy should be continued. So if your patient is taking...
Dr. Niaz, sorry for interruption. We have 1 to 2 minutes to conclude,
Yes,
please.
yes,
We
yes.
just passed the time limit. Thank
Yeah, 4 pregnant patients. So I think just Omid, you can discuss in questioning answer. Now, what about the non-hospitalized patients? COVID, anticoagulants, and antiplatelet therapy should not be initiated for prevention of VT, arterial thrombosis unless the patient has other indications. This is same thing now. COVID outpatients receiving warfarin who are in isolation and thus unable to have INR monitoring may be switched to the DOACs. On the other hand, if the patient is taking warfarin because of the atrial fibrillation, valvular atrial fibrillation, then you have to continue the warfarin. Treatment, when diagnostic imaging is not possible, then you can go and treat the patient as on clinical grounds. And then there are a lot of ongoing trials, determining the role of fibrinolytics, antiplatelet agents, antithrombotic agents. About 40 new trials are expected in next few years. So the take-home message is that COVID-19 disease predisposed patients to arterial and venous thrombosis. Both micro and macro thrombotic events can occur. High-risk patients can be identified by coagulation parameters, D-dimer, PT, platelet, fibrinogen, FDP, TEG. All patients should be placed on VT prophylaxis, preferably with a low molecular weight heparin, unless there's a contraindication. And a strong clinical suspicion of VT with suggestive parameters may be just enough to diagnose and treat VT without confirmatory imaging. Therapeutic anticoagulation should be strongly considered in patients at high risk for coagulopathy, those who are requiring renal replacement therapy and ECMO, or those patients who have got signs of a microthrombi-induced organ dysfunction, or those who have got macrothromboembolic event. Now, aspirin should be considered in cases with elevated troponin and cardiac dysfunction for the cardiac prevention, not for the VT prophylaxis. So thank you very much.
Thank you very much, Dr. Niaz. I'm just going to take a few questions before we conclude. Is there any rule to add aspirin to the anticoagulation protocol when treating COVID patients?
As I mentioned, you see, if the patient is taking aspirin because of the cardiac indication, then it has to be continued, but there's no rule for the VT prophylaxis of the aspirin.
Okay, and if the patient is taking, if we have like cardiac patients with ischemic heart disease, he was taking aspirin and the Plavix, would you still give him anticoagulation, or would you stop the antiplatelet and give the anticoagulation instead?
Now, this is a good question, because we are talking of this depends on if we are giving for a prophylactic agents, as a prophylaxis, VT prophylaxis, then perhaps we start one of the antiplatelet agents and then I continue with aspirin or clopidogrel, or either of them along with anticoagulations.
Okay.
Because these patients, they are at high risk of bleeding also. In fact, I can remember 2 or 3 of my patients, they developed retroperitoneal hematoma while on anticoagulations and aspirin. So you have to be very careful, but at least one antiplatelet agent has to be continued along with anticoagulants.
Okay, and for a patient who is already on anticoagulation, is it contraindicated to take the AstraZeneca vaccine? I received one question.
No, I don't think so. Someone is because intramuscular, because these are the intramuscular. One thing is, this is a very technical new thing you're talking about. Perhaps we can omit one dose if the patient is taking intramuscular injections. So one dose of, depending on which agent he's taking, So if he's taking DOACs, then one dose may be omitted, and then in the afternoon, because most of the DOACs, even for pre-operative, we only stop for 12 hours, not more than that, So omit one dose, and then one dose of DOACs in the morning, and then, or at least if the patient is taking, so minimum 12 hours has to be elapsed before the patient can give a vaccine.
Okay, thank you, doctor. Will a patient with history of DVT considered as a high-risk patient to start anticoagulation?
Sorry, what did you say? Say again?
Yeah, will a patient with history of DVT, or I think the question mentioning that the patient has history of VT, would he be at high risk of?
Yes. This is one of the parameter of pedo scoring system. Anybody having previous episode of the VT is a high risk of developing VT, so therefore they are a high candidate for a VT prophylaxis.
Okay. Okay. So thank you very much, Dr. Niaz. I would like to thank Dr. Jihad Abdullah for being with us, and I'd like to thank him for his rich session, and I would like to thank also Dr. Niaz Sheikh for his excellent talk. Thank you all for attending, and we will meet you again with another COVID session, as this year will be dedicated for COVID-related topics. So stay safe and have a good night. Thank you very much.
Thank you very much.
Thank you. Have a good night.